So, hi everyone. Thank you so much for joining us today. My name is Priya Raman. I will be facilitating our webinar today called Navigating Together, Addressing Lung Cancer Screening in the Asian American, Native Hawaiian, and Pacific Islander Communities. On our team, we have Jay, who's going to be also presenting. She's our program associate, and you'll hear from her in a little bit. Go to the next slide. Just some Zoom reminders. This webinar is being recorded, so as participants, your audio and video will be muted. If you have any questions or comments for our panelists or for us as well, you can drop them in the chat box or the Q&A box that's up on your screens. So we'll just get started here. So just a little bit about APPEAL. So APPEAL is the Asian Pacific Partners for Empowerment, Advocacy, and Leadership. It is a national organization working towards social justice in an equity-centered, healthy, tobacco, and cancer-free community. We work for a healthy, equity-centered living for all populations, primarily focused on the Asian American, Native Hawaiian, and Pacific Islanders. And that is our logo. Oops. Let me share my screen again. My PowerPoint went away. There it goes. Okay, what is APPEAL known for? APPEAL is known for their work in leading efforts for the AA and NHPI communities, specifically addressing commercial tobacco use and prevention, addressing cancer prevention and control, addressing COVID-19 misinformation, healthy eating and healthy living, opioids, health equity, and capacity building and advocacy. And if you look on the side, you can see some of the previous pieces we've worked on. So we've done one with ASQ and the TIPS campaign, which was all about cessation for our Asian American communities, along with a NHPI-based secondhand smoke material we did. So how does APPEAL provide support? We provide support in the form of technical assistance, whether that's providing information on culturally and linguistically appropriate tobacco education materials, data on AAPI, tobacco issues, guidance and input on program-related actions, for example, cessation or secondhand smoke, guidance and input on policy-focused issues on the tobacco industry sponsorship or settlement funds, along with letters of support. As a team, we also provide lots of trainings related to tobacco's impact on the AA and NHPI community, cultural or community competency, leadership development, AA and NHPI youth mobilization, capacity building, coalition development, advocacy, and policy development. On this slide, there's just some pictures. This was a picture we took in DC this past June. We held a leadership training. And so this is a picture of our team plus all of our fellows. We had fellows from over 8 states, including the jurisdictions and Palau. And then this other picture up here is a picture of our 2 fellows with Elaine Ishihara, Dr. Kittner, and Rod, our executive director. They presented at our APPEAL Cancer Policy Summit that was also held in Washington, D.C. back in June. And this quote just says, "It was wonderful community building and challenging, but in a good way, in a way I needed. The activities truly helped me reflect on who I am, how I want to apply leadership, and how I want to be a better advocate and part of the community." Just a little bit about the communities that we work with. So we primarily work with the Asian American, Native Hawaiian, and Pacific Islander communities. These communities are very diverse. They represent over 50 countries and speak over 100 languages. And many times our communities are targeted by the tobacco industry as a way to promote tobacco products. In particular, in our countries, we see that being sold as part of this American dream. And so when people come to America, they tend to use these products pretty commonly. And through data, we know that sometimes it seems like our communities are not being impacted by tobacco the same way as other communities are. But when we disaggregate the data and look at them by subgroups, we actually see their prevalence data is much higher than even the nationally reported one. So specifically the Korean, Vietnamese, Chinese community, and also in the Native Hawaiian Pacific Islander community, we see high rates of menthol. They're actually the second highest menthol use And also youth in the NHPI community have some of the highest use of vape products. And just some stats about lung cancer screening rates. So we picked this topic because of the overlapping piece around tobacco use and also lung cancer being affected by that. And so lung cancer is one of the leading causes of cancer death among the A and NHPI community. We know that smoking harms your lungs and can increase your risk for lung cancer. And getting screened for lung cancer early can actually help save your lives. And when we looked at the data, we actually saw that the AA and PI community who had lung cancer were actually 17% less likely to be diagnosed early in comparison to the Caucasian community in the United States. And if you look at this chart, you actually see that the early diagnosis rates are low, which means that their surgical rates are much higher and their lack of treatment is actually a lot lower. And I will pass it to Jay to read our bios for our panelists.
Thanks, Priya. So I want to introduce our three wonderful panelists today. Our first speaker is going to be Dr. Jeffrey Valletta. Jeffrey is a Bay Area native who moved to the East Coast to begin his medical school at George Washington University. He then returned to the West Coast to start his general surgery residency at UCLA Medical Center. During his time, Dr. Valletta also completed his postdoctoral research in the Department of Cardiothoracic Surgery at the Stanford University School of Medicine. Following this, he completed his training in cardiothoracic surgery at Brigham and Women's Hospital and Harvard Medical School. Dr. Valletta's clinical and research interests involve innovative techniques, regionalization pathways for lung cancer. In addition, his most recent research involved improving lung cancer screening uptake in Asian Americans and identifying key factors in the rising incidence of lung cancer in non-smoking women. Our next speaker, we'd like to also welcome Nashia Chowdhury. She is the Director of Programs of Healthcare Transformation at the Association of Asian Pacific Community Health Organizations, also known as APCHO. APCHO is committed to advancing advocacy, collaboration, and leadership to improve the health status and access for Asian Americans, Native Hawaiians, and Pacific Islanders. Nashia co-directs and oversees APCHO's program and services for training and technical assistance, disaggregated data advocacy, workforce development, and health center partnerships. She also manages the National Training and Technical Assistance Partners Grant and leads partnerships focused on enabling services, data collection, and social needs interventions. Before joining APCHO, Nashia served as the Data and Evaluation Manager at the National Association of Community Health Workers. She was a Director of Operations at a federally qualified health center in Michigan and was the Associate Director of Operations and Enabling Services at the Michigan Primary Care Association. And finally, we have Elisa Tulua. Elisa is the Executive Director of the Southern California Pacific Islander Community Response Team. This organization is a culmination of 15 plus years of learning in community-based nonprofits serving Native Hawaiians, Pacific Islanders, and Asian Americans and other communities of color. She is most proud of her development as an organizer, strategist, and advocate rooted in community-driven approaches, nurtured through the encouragement, investment, and belief of NHPI elders, leaders, and women of color who have mentored her. Elise also has a Master of Science in Biology and a Bachelor of Science in Biochemistry, Biology from UC San Diego. And I'll pass it back to Priya.
Thanks, Jay. I'm going to pass it over to our first speaker.
Okay, let's see if I can get this right, guys. Okay. Okay, so hopefully you're seeing my screen. I see thumbs ups, maybe, or okay. So yes, so thank you to Priya and Jay, and thanks to the rest of Appeal for, and obviously really excited to hear the other panel members talks. But anyways, what we'll talk about today is a little bit an overview of lung cancer statistics, because I think you need to know that, but Priya did a really good job of explaining that. But also, how does it relate to the AA, NH, and PI community with regards to cancer in general? And then we're going to get specifically a lot of some of the areas of research that I'm interested in, and show you some data today that hasn't been published yet. So we're going to present some hopefully novel insights into lung cancer screening as it relates to the Asian American, Native Hawaiian, Pacific Islander community, and basically not only to show kind of that what if there is disparities, which I'm going to show you there are, but how do we improve that disparities, right? So hopefully some calls to action, and hopefully motivate future collaborations with either my panelists on this screen or to the audience. So happy to take discussion afterwards. So as Priya mentioned, this is the most recent data that we all go by with the American Cancer Society, is that lung cancer, regardless of men and or women, regardless of race, ethnicity, it is the #1 cancer killer, and it's not even close, right? It is the #1 cancer killer, and there's nothing else that even comes close to this. So we pose this question, right? Why are we not talking about this every day? And so I think this is something that hopefully brings home that point. And again, the idea behind lung cancer, the reason why it is the #1 cancer killer and why mortality is so high is because we catch it late. The majority of times, only a quarter of the time, about 24% of the time, will we catch it early. Okay. The majority of the time, meaning regional or distant, it's caught at a way later stage where treatment isn't as good. You can see when you catch it distantly, 46% of patients diagnosed in the United States are caught at stage 4 disease, where your 5-year survival is 7%. Okay. Versus if you catch it early, 24% of the time, which is still very low, your survival is 61%. So much better, but still not perfect. So a lot of rooms to grow. And so when we think of, there's a lot of buzzwords that Priya was talking about when we think of appeal. And yes, we know that smoking and lung cancer is a big deal, right? The risk is 20-fold higher if you're a smoker versus a not smoker or having a smoking history. But again, it's not the whole story. Okay. So yes, we want to concentrate on tobacco cessation and all of that. And that's still very, very important. But what I'm going to show you in the next slide is that about 20% of lung cancer in general is not even related to smoking at all. And it actually hits the Asian American community even harder. And so when we go over that, secondhand smoke, right? We know secondhand smoke is an issue. And there's even newer data to show maybe it affects certain communities more than others. Previous radiation for other types of things, other types of cancer, whether it be breast cancer, lymphoma, all those things, nothing that you as a patient can do anything about, but if had that exposure, your risk of lung cancer goes up exponentially. But what about occupational exposures, right? We forget about all the different, whether it's construction or mines or healthcare exposure, right? Nail salons, all things that we may take for granted, but that a lot of different in our Asian American community are a part of. And then the most common cause of non-smoking lung cancer is actually radon. And then for the audience, maybe this is a very experienced audience, but I'm assuming we have all different kinds of people and explanations. But radon is very, very common, and in fact, so common. There's a lot of states now that are requiring when you buy a house, you have to get a radon test, which is a very simple, easy test to get. And it comes from basically the soil, as you saw in the picture in the upper left-hand corner, right? Uranium slowly decays, and it's just in your soil. And you don't even know, right? You don't even know that that's happening. But just generally, right? Indoor, outdoor pollution, right? Certain areas, if you look at particulate matter greater than 2.5, which is that hot new topic that you'll hear about, particulate matter 2.5, I don't know if many of you know, and I didn't have a slide for this because what my whole talk is on, but California actually has the highest amount of particulate matter 2.5. And I know this is a national organization. I'm actually in the Bay Area. So we see a lot of this that's a hot topic. But what about history of tuberculosis? As many of you know, many of the Asian American, Native Hawaiian, Pacific Islander were affected by TB in the past, were treated very easily or didn't even know. That's actually a big risk factor for lung cancer. And any type of interstitial lung disease, autoimmune disorders, Sjogren's syndrome, a lot of things that you see in Asian Americans, and COPD, just in general, idiopathic pulmonary fibrosis, dramatically increases your risk of lung cancer, regardless of smoking. And another buzzword, right? This is coming on the map. These are the only 2 studies that I know of, and one of them's not even published yet. Vaping and smoking synergistically leads to way higher lung cancer risk. Okay. But even if you quit smoking and you continue to vape or e-cigarette, your risk actually goes up even higher. So we know vaping is actually going to show it. We don't know how strong the risk factor is, right? But I will tell you, vaping's only been going on measured since the mid 2000s, and we're already seeing lung cancer risk even after 5 years of recent data. And this is recent data from Korea. But I will tell you that vaping, again, we don't have hard data on this, but it's probably worse than tobacco smoking by exponentially. Okay, so more on the rise. Okay, what is lung cancer screening? This is a picture of one of my patients, getting screened. It's super easy. It takes a minute. It saves your life. You heard that. There's been two randomized controlled trials showing a 20% reduction in lung cancer mortality. That's why this is covered by the government. The radiation dose is safe. There is no excuse why you should not get this CT scan. It is covered by Medi-Cal, even if you don't have insurance. Right now, we still have Obamacare, right? It is still covered. What are the guidelines for this? If you're 50 to 80, you currently smoke, or you have a 20-pack year smoking history, you qualify for this, regardless of insurance status, okay? So this is a test. This is what the test that we're talking about when we're saying lung cancer screening. It's a low-dose CT scan. All right, so now let's go into just overall and the Native Hawaiian Pacific Islander disparities in cancer. It is the fastest growing U.S. racial group, right? Oh, more than any. Everybody on this call may know that 24 million Americans. Cancer is the leading cause of deaths in the Asian American community in both men and women. It is not heart disease as it is in every other race ethnicity. We know that research from the NIH budget is just does not fund Asian American, Native Hawaiian, Pacific Islander research. 0.17% of the total NIH budget is in this population, right? This should anger people. And how do we improve that, right? The clinical trial participants, right? If all the clinical trials in medicine, including lung cancer screening, were not done in Asian Americans, no wonder that we're seeing differences in smoking rates, differences in mortality in Asians versus non-Asians, because we're not studying those. The two clinical trials for lung cancer screening, the majority were not Asian American. And Susan Shinagawa, who I don't know personally, but she is a breast cancer survivor, she sums this up perfectly. Our problems never make the headlines, right? How do you see these problems? Do you see me on the news? Yes, even if you do, although I am on the news, you probably never even seen that, right? So we need to speak out more. Lung cancer. This is another terminology that you heard. Disaggregation, right? This is really the only study that's been published that shows disaggregated lung cancer death for Asian American groups, right? This should be all over the place, but it's not. We often aggregate all the data, but even when you disaggregate the data, look at for men, it is still the #1 cause of death, regardless if you're Korean, Japanese, Filipino, Asian, Indian, South Asian, all of the above, right? Women not as high in certain things, but still high, okay? So even when we disaggregate the data, lung cancer is a problem. And so the other thing that we look at is that the Asian American, Native Hawaiian, Pacific Islander are historically underscreened for other cancers as well, right? The three most common that we get that everybody here screening on is breast, colorectal, or prostate. But you can see even in that population, we do very poorly. And I'm going to show you in lung cancer screening, we do the worst, right? So we need to reveal what the what the disaggregated groups are, which is I'm going to show you some data for disaggregated Asians. And obviously, many of you may know what the model minority myth is. I will sum it up. Everybody sums it up a different way. The way I sum it up is all people, whether you're white, black, Latin, a health policy person, a normal person, the model minority myth is all Asians are the same and we're all healthy and we're not sick and we all look like I do and we all speak perfect English. And we obviously know on the call that we're not like that, but that's how we may be viewed with regards to us as a overall Asian racial ethnicity in the scientific world. And that's clearly not true. And we're going to hear more of that from our other speakers, I'm sure. So the research that I'm going to show you on is from the Kaiser Permanente Northern California Health System. Regardless, there's 8 different states with Kaisers, but for me, I'm in Northern California, Oakland. Okay. So all you need to know what it means is that it's 3 tiers. We have the insurance plan, we have the hospital systems, the 21 different hospitals in Northern California, and then we have all the doctors and nurses. So it's 3 different systems, but the idea is insurance isn't an issue because you already have to have insurance somehow to be in our system. And then the data is going to be really, really good, right? Because we could track all these people. But again, it is limited to just our healthcare system that I'm showing you this data for, that we're going to show. And the first thing that we're going to start it off with, we looked at just lung cancer screening, right? Lung cancer screening uptake overall in our Kaiser Northern California system, that if you're eligible for lung cancer screening is only about 4%. So that should baffle you, right? So why is that happening, right? Where I tell you breast, colon, and cervical in the Kaiser system is 80 to 90%. Lung were 4%, okay? And out of that 4%, basically Asian American, Native Hawaiian, Pacific Islander, Black, and Hispanic, all across the board, are much lower lung cancer screening rates, even in an insured system in Northern California. We're 25% less likely or 33% less likely, depending on race ethnicity you look at, to get lung cancer screening currently than white patients, okay? So we looked at that, and I'm not going to go into that detail because I want to go over to the disaggregated data. We looked at that and we're like, this is weird. What's going on? A lot of my research, which I relate to, I'm Japanese American, is in the Asian American research. So I wanted to disaggregate that, right? And luckily in our system, right, which you can't do at a lot of health databases or a lot of national databases, but we can disaggregate the data. So then we wanted to look at what's the difference between different guidelines, different screening guidelines up to date, but basically what's the difference between different Asian American racial subgroups. And you can see, I didn't go into the detail with this, but 2013 guidelines were very different than 2021. The 2021 guidelines are the ones that you have to look at now. And part of the reason with doing 2021 guidelines was to open it up to women and minorities, specifically Black patients. They didn't really care or think about Asian Americans in that, but turns out this is real data. You can see that 2000, basically 2,200 Asian American, Native Hawaiian, Pacific Islanders were eligible in our healthcare system under 2013 guidelines. That increased by 156% to 5823. So it did actually improve Asian American eligibility and Native Hawaiian Pacific Islander eligibility as well. So that's good, right? So then what we wanted to do in this study, and you can see we broke it down on the screen on the left, but look, there is differences, right? There's different amounts. We can break it down to Chinese, Filipino, Pacific Islander, Japanese, Southeast Asian, Vietnamese, Korean, Asian others. So it's still not perfect, but it's still pretty good. Still pretty good that we can do that, right? And we can look at what's your eligibility and what's your screening rate, and is there differences based on sex and different Asian ethnic subgroup. Turns out, I don't want you to look at the bar graphs. You can look at the bar graphs, but all you need to look is to the left. Chinese males and females in our system are the highest screened rate. The lowest screen rate can be anywhere from Southeast Asian and Vietnamese females were the lowest screen. Why is that, right? So that's what we need to study a little bit more and more. This is just showing another graph of looking at the different guidelines, 2013 to 2021, with broken down by the disaggregated groups, so different racial ethnic subgroups. Bottom line is, the in parentheses is the lung cancer screening rate, and then next to that is the amount that are eligible. All you need to look at is, regardless, even though there's differences between different racial ethnic subgroups, it's poor all across the board. Nobody hits even 10%, right? 10%. So the majority are anywhere from 0%, so nobody gets screened that's eligible, to as high as maybe 7 to 8%. So again, all bottom line, there are differences between different racial ethnic subgroups, but it's poor all across the board. So take-home points for this. Yes, there is heterogeneity. You all on the call know this, right? Between different Asian American, Pacific Islander, Native Hawaiian, Pacific Islander subgroups, there are differences in with us, and there's differences in screening. But bottom line is, regardless of what subgroup you belong to, we do poorly. We don't get lung cancer screening. Hence, our lung cancer screening rate, or hence our mortality is high as well. All right. So then we said, call to action. What's going to make a difference? Well, I got a grant funded. So this is a big step, right? This is the first grant given by our Major Thoracic Surgery Foundation grant to actually give a grant on Asian Americans, specifically as it relates to lung cancer screening. And the idea here, these are my lay navigators. We're going to help with lay navigators. And so this is a presentation that we just submitted. I do a lot of research with UCSF and as Kaiser as well. And we submitted this. It hasn't been published yet, but we basically looked at the idea of evaluating the effectiveness of a community health worker, a community health navigator, to go out virtually, talk to these patients in different Asian American racial ethnic subgroups, and try to improve the lung cancer screening rate by helping them through the whole process. So the idea is, we took 500, you can look at this slide if you want, or you can just listen to me. Basically, like, we looked at 500 Asian American, all different subgroups, and basically compared that to another 500 So 500 they were all eligible for lung cancer screening based on their smoking history and smoking criteria and age. And when we compared 500 that had a navigator helping them versus 500 that didn't, and then we wanted to see, was lung cancer screening improved? And yes, this is a preliminary result, so the numbers are still low, but you can see dramatically increases, double the amount of lung cancer screening referrals, more shared decision making, meaning more people going in to figure out about whether they qualify for lung cancer screening, whether they want to do the test, and more low dose CT scans. These are just preliminary numbers, but bottom line is active outreach, meaning a lay navigator, does help Asian Americans get their screening test. So that's the take home point. Lay navigators help. But this was just a pilot study, right? This is just checking it out. We don't have this across the board. So we need future studies to look at patients like this. And if they do like this, because our data shows that it works, but if the patients like this too, which I already have preliminary data showing that they do, let's go ahead and hire more of these people, or let's get funding for this, right? To get navigators out to improve it. So in summary, lung cancer is the #1 cancer killer in the AA and HPI community. How do you prevent that, or how do you reduce that number, improve mortality? You get lung cancer screening. But I just showed you screening is super low in this population, right? No matter what, all across the board, every different disaggregated population, it's low. So one of the calls to action that I think is going to help, and everybody could be doing their part across the country, everybody's doing different things. But for me, my big take is we need funding for community health workers, right? That's what I think we need to do to get out, and specifically community health workers that can speak the language, because I don't speak the language, right? I don't even speak Japanese. I don't speak Chinese. I don't speak Mandarin, Cantonese, all that. When I'm even doing it as a doctor doing it, they don't relate as well. I have it with a translator, but it doesn't work as well. It's just not as well as if we had a lay navigator that speaks the language. So I think that's the bottom line. So that ends it, because I went over time a little bit by a couple minutes, but I thank you, and I look forward to hearing our other speakers. Thank you.
Nashia, we'll pass it to you till Jay pulls up your slides.
Sounds good. Thank you so much. Thank you, Dr. Velara. That was a lot of helpful information. I know you already have some questions, so look forward to hearing the answers after. So hi, everyone. I think it's afternoon for folks on the West Coast now, so I can say good afternoon. As Jay mentioned, my name is Nashia Chaudhry, and I am sharing about some of the work that we have been doing here at APCHO. And so I will be speaking to our Community Health Worker Workforce Collaborative. This was work that we recently tied up, and I want to share some of the promising practices that we learned, some of the lessons, and then some opportunities that we have here at APCHO if you would like to be involved in continuing to get resources and join different events that we have specifically tailored for CHWs. So on the next slide, I do want to share quickly about APCHO. So the Association of Asian Pacific Community Health Organizations, otherwise known as APCHO, was formed about probably more than 35 years now, 35 years ago, to create a national voice to advocate for the unique and diverse health needs of Asian Americans, Native Hawaiians, and Pacific Islander communities, and the community health providers that serve their needs. So I will transition over to the next slide, just briefly talk about what is a community health worker. So in the next slide, I've shared some documented benefits of CHW programs. So I feel like I'm speaking to the choir in terms of talking about the work that CHWs do. So as we chat about who are community health workers, it might be a little bit small if you're looking on the screen, but just briefly, CHWs are really trusted members of the communities that they serve. They generally share at least one characteristic with their patients, and this can be place or where they live, race or ethnicity, or health condition. And they generally act as liaisons between patients, clinical care, and social services. So why are community workers unique? Generally, CHWs connect patients connect with patients as peers and not as clients. Their expertise generally is in the ability to establish those trusted relationships based on shared experiences with the populations they serve. And they generally spend a lot of time providing in-person support, which allows for patients to have greater adherence to treatments and to work on disease prevention strategies. And generally, community health workers are utilized to strengthen health promotion efforts, and they are very responsive in terms of being able to tailor the care and services that they provide to the patient populations, because as we mentioned, they generally are from those communities. They generally have shared experiences, they have backgrounds that they share, and so are able to build those trusted relationships. Briefly on the right side of the slide, quickly just want to mention a couple of things. So as we've worked with community health worker programs in different states, some of the increased improvement in terms of serving the communities has been in focusing on social determinants or drivers of health, being able to connect our patients to various community resources. Culturally appropriate care or culturally responsive care is a big one, especially as we work within our communities. As Dr. Vallada mentioned, being able to speak the languages, being able to understand the different communities and what their needs are, what are different barriers to serving those in those communities is very important as we address different chronic conditions. Management, like I said, management of chronic conditions. So being able to have those conversations, guide them through the process of getting treatment. What does that look like? A lot of times we come from communities that are not just focused on patients, but what does that mean for family members? What does that mean for other community members as we're going through a process of identifying and treating patients? Patient satisfaction increases when there are CHW programs. ESL is a big one. So patients with limited English proficiency, how are CHWs able to serve them? They also are able to provide support for behavioral health services, care coordination, in rural populations or populations that don't necessarily have quick access to care. They're very important in being able to do outreach and education. And then, of course, overall having cost savings for healthcare organizations. So briefly, on the next slide, I will share a little bit about the background of the Community Health Worker Workforce Collaborative that APCHO supported. And so if you go to the next slide, just briefly about the Community Health Worker Workforce Collaborative. It was a national partnership of community health organizations. So it's community health centers as well as community-based organizations. And really the effort was to expand local COVID-19 vaccine outreach and education initiatives. So on the following slide, you will see a map, and this identifies all of the different organizations across the U.S. That we worked with for our CHW Workforce Collaborative. So we were in 32 different states, 55 different community health centers and community-based organizations that were supported through this grant funding initiative. On the following slide, you will see the list of all the partners. So I won't go through them right now, but if anyone's interested in taking a look, one thing I do want to mention, you'll see in front of some of them, it says NAOPO. So on the next slide, I actually mentioned our NAOPO partners in particular. So the National Association of Pacifica Organizations, we worked specifically to increase our efforts for outreach and education into our NAOPO partnerships, especially with the round 2 of funding to be really able to support our Pacific Islander partners. And so out of our COVID-19 funding, we were able to establish and work with these new CBOs to make sure that we were providing COVID-19 outreach and education in the PI communities. So on the following slide, you will see that through the work of this initiative, we were able to provide and assist various communities and provide these services in over 36 different AA and HPI languages. And so, we listed out what all of those languages are, but really being able to provide them in these languages also included doing some work and being able to translate a lot of our materials into different languages. And so we were able to translate all of our documents, the different surveys, a lot of the resources into 19 different languages. And actually, we worked with one of our partners on the collaborative to be able to provide those services. So on the next slide, just briefly going over the partnerships. So APSHO's role in terms of being stewards of the funding and holding the funding source, but being able to push this out into the communities across the 55 partners was really also providing administrative support to the local partners who were doing the work. And so in the beginning, when we set up the Workforce Collaborative, our efforts were really in doing community assessments, sending out surveys, having conversations with the different organization leads, and being engaged so that we could determine what sort of resources we needed to provide. So, being able to provide the in-language surveys in 19 different languages was just a part of it. A lot of it was also making sure that we were hosting monthly calls to chat with different leaders that were pushing forward this initiative. We had monthly CHW peer-led space for CHWs to come together and talk about challenges, talk about successes, highlight different activities that they were working on, and then really also co-designing the supports. So it wasn't just the staff at APSHO deciding what was best and what needed to be provided for our partners to be able to do the work, but also having our partners sit in on different work groups to give us feedback and let us know what their communities really needed for them to be able to move forward. And so on the next slide, just quick picture collage of all of the different sorts of activities that were happening utilizing this funding. So a lot of COVID-19 vaccination sites. We had a lot of our health centers who were able to provide the vaccinations on site, but then we also had a lot of partners who worked with different community members, whether that was a local pharmacy or a local health center or like a back to school drive. And so they were able to utilize all these spaces to be able to share share these different resources that they had available. So on the next slide, just transitioning into the impact of the work, some of the promising practices and lessons learned from our collaborative. So briefly sharing some statistics on the following slides. So again, as I mentioned, we had 55 different partners across 32 states. And so, that's a really big push in terms of making sure that we were connecting with a lot of the AA-NHPI communities that we saw come up in needs assessment and surveys of where the pockets of our communities were, and then finding health centers or CBOs that we can work with and provide funding to so that they can go out and do the work. If you take a look at the vaccine doses delivered, that's over 152,000 vaccines across all activities, including assistance, outreach and education, and vaccine doses delivered. It was over 3 million activities. And a lot of times when our CHWs were in the field and having conversations about answering questions about why people weren't getting vaccinated, or if it was an access issue, or if it was a scheduling issue, a lot of times when they were having those conversations with people in the community, they were learning about other access needs. And so they were also, while they were there, able to address other SDOH that came up in those conversations and also continue to support members in that way. One of the notes that I do want to highlight on these stats is that through this collaborative, we were able to hire over 762 community health workers across all of the organizations. And for us, that's a big deal, right? If you look at the next number, 88.5% of these CHWs were hired directly from the community. And going back to the ongoing conversations about what does it really look for us to be able to serve our own communities, a lot of time it's just having a conversation in that native language, right? Or being able to help translate an article, or being able to help translate a survey. And so a lot of times being able, you're talking to folks in your community, whether it's another church member or it's the person at your local grocery store. And so being able to connect and build those trusted relationships was very important for us to be able to do this work. On the following slide, just briefly sharing what were some of the reasons that people were getting vaccinated. And so this is a survey that was provided for anyone who completed vaccination to help us gather some of this information and to help tailor ongoing outreach and education activities. And so if you take a look at this, the highest number is the blue column all the way on the left, and you will see that's specifically directly related to outreach. So outreach was a big part of why folks were coming in to get vaccinated. If you take a look at some of the other columns, one of them is websites or social media, community events, community center, electronic communication, broadcast media, printed advertisements, social interactions. So all of these different methods of getting in communication and contact with the local communities were utilized in various ways by our community workforce collaborative members. And so I remember having conversations with people about, do we send a letter or do we get on WhatsApp, or what are the different ways that we can specifically tailor our messaging for different communities that we engaged with. And so one of the ways was getting on some of the local news channels. Some of them was getting on the radio, ethnic media, ethnic newspapers. So there was a wide variety of ways that our partners were utilizing the different marketing materials to be able to reach their communities. So just briefly, a quick testimonial on the next slide, which I will read really quickly. I really like to highlight this testimonial. It was from one of our partners, one of the community health workers that shared with us of an experience that they had with a patient. A certain patient was hesitant to get vaccinated, but agreed to be scheduled for vaccination anyway. She arrived an hour early for her morning vaccination appointment, but hesitated. The clinical staff, community health workers, and fellow patients tried to encourage her, but she refused. Yet she did not leave the site. She sat and watched the other patients receive the vaccine, and the CHW, who speaks the same language and is from the same culture, continued to educate her and reach out to her. Finally, after 3 hours of waiting, she decided to get vaccinated. After she got the vaccine, the staff and patients clapped, danced, sang, and cheered for the patient. It was a very happy moment. The same patient served as an encouragement to others in her community to receive the vaccine. This is an example of how a CHW makes a difference motivating and educating patients to receive the vaccine, especially if they share the same culture and language. So the reference is a CHW at Kalihi Palama Health Center. And actually, one of the reasons I like to highlight Kalihi Palama, they are a community health center, and they worked very closely with We Are Oceania, so one of our PI partners out in Hawaii, to be able to provide services specifically for our PI communities out there. So briefly on the next slide, again, I just wanted to highlight some of the promising practices. One of our main ones was always working with our partners to be able to hire from within the communities that we were focused on serving, especially our AA and HPI populations. Focusing on those local partnerships and collaborations. So when they were going to outreach events or when they were going to vaccine clinics, it didn't mean that that one organization had to do it by themselves. They were able to have agreements, they were able to build partnerships, they were able to really tap into the resources of the local communities that they already had in place. Providing resources in language. So, going back to being able to provide and translate a lot of our materials into the 19 different languages. And we were really glad to be able to do that because that was one of the things that continued to come up. And so we were able to also put those resources onto our website so other folks could also access it as needed. Again, mentioning that our CHWs were serving our patients and our communities in over 36 different languages. And they were not, and it wasn't just documents, right? They were able to translate, they were providing interpretive services, they were making informal referrals as other needs came up when they were meeting with communities about coming to get vaccinated. So if it was issues with getting access to transportation, or they were having conversations about getting vaccinated, but someone didn't have a primary care physician, being able to build those relationships and refer them to other people was really primarily also a focus while doing the COVID-19 outreach. On the next slide, we have our lessons learned. So just briefly, one of our biggest factors in terms of being able to do the work and schedule the vaccinations for our communities was being able to coordinate. As if you all think back to the beginning of the pandemic, when there was a lot of shutting down of services and times, just wanted to point out that this was a lot of coordination efforts that needed to be considered if we thought about folks being burnt out and being able to actually be of use and service to folks in the community. Quick reminder, just that, if people were going into the communities and running into folks who were refusing to get vaccinated, that they should still provide resources to get tested, to come back if they decided to change their mind, any other resources that were available to still make sure that these communities had access to the other outreach and education efforts. And then, of course, addressing language barriers earlier on and being able to pivot and provide those resources in different languages. Okay, so the next slide I really want to focus on is, what does that look like? So I spoke a lot about COVID-19 outreach and education, but what does that really mean, and what were the lessons learned in being able to support CHWs in this role? So really highlighting what are different opportunities for CHWs as they work in a role where they are addressing tobacco use and providing support for cancer screenings. So if we go to the next slide, really providing a quick overview of the different initiatives. So education and awareness is a really big one. You can see that theme in the slides I shared about the CHW Workforce Collaborative, generally being able to provide culturally relevant information on risk factors, being able to explain the importance of early detection, and really combating myths and misconceptions that generally will come up in different communities that you work with. They might have heard something from others, or they might have some belief that is generally maybe not true. And so how do you have those conversations in a culturally responsive way to make sure that you are bringing in people to be able to better understand what is, then why is there such a need for getting screenings? Then we have outreach and recruitment. So you really want to build those relationships with trusted community leaders and members to be able to further expand your outreach and recruitment efforts, targeting your outreach to high-risk communities, promoting screening tools and programs, and really building trust within the community. And generally, going back to what I mentioned earlier, when you're looking to build trust within those communities, you really do want to focus on bringing on CHWs and outreach workers who are from those communities and are able to connect with those community members as well. And language access is a really big piece of that. As Dr. Vallada mentioned, sometimes we are from those communities and we may not be able to communicate in those languages that folks need to be provided additional support with. And sometimes CHWs are bilingual, multilingual, and are able to bridge that gap with our community members. Then we have navigating the healthcare system. Generally, this really helps with screening access. Sometimes, you want to go and get screened, but you don't know if your insurance covers it, or you don't have insurance, or you need assistance with finances. And so CHWs are generally aware of some of the resources that are available and can help to guide that process. Another SDOH that may come up is transportation, right? So sometimes CHWs may want to get to an appointment or would like to be able to work around their schedule, but they might not have transportation available. So different drivers of health that impact a person that CHWs can help to navigate and facilitate that sort of support within the community. And then also being able to connect with culturally responsive providers. A lot of times we have providers in our network that we are able to connect them with, and they might feel more comfortable seeing someone who is also from their community as well. And then one of the big ones that I do want to highlight, and it's been an ongoing conversation in other areas too, is the use of traditional and Western medicine. And sometimes, we focus a lot on the Western way of providing care, and we may disregard or may not see this as the best place to also consider traditional medicine and traditional ways of supporting different communities. And so including that in conversations. A couple of other points I do want to mention is when we are having culturally responsive messaging and engagement, as I mentioned before, sometimes you're not just having conversations with families, but also, patients, but also with their families, right? So if there is a diagnosis, what does that mean for the patient? What does that mean for the families? What does that mean for their support systems? And a lot of times that does lead to having conversations around cultural stigma, or what are the barriers that are causing a person to stop seeking care, or don't so what are some of the barriers that keep a person from seeking care? And sometimes that also means incorporating support groups and programs and other wellness focused activities that can be tailored to a specific population, right? So AAs and AHPIs. And really also focus on advocacies. CHWs are really those trusted members for our communities. And so when they're working with their patients, they're really serving as advocates for those patients and helping to address their needs as well. So I know I talked a lot, and I could go on, but I do want to just go to the next slide and also refer you to some ways that you can get connected to APSHO and receive emails, events, action alerts, different resources that may support you all as you work with your CHWs or your healthcare providers or your communities. One of the ongoing ways that you can do that is to sign up for our newsletter. So if folks are interested, we can share the link with you. I don't know if Jay can drop that in the chat, but please feel free if you're ever interested in some of our activities that include learning collaboratives and webinars, and some of them are really tailored for CHWs and enabling services staff. We would love to have you all join us and share about the work that you all are doing as well. So with that, I will go ahead and share the training email address if folks are interested or have any other questions, and I will pass it back over to Priya. Thank you.
Thanks, Nasha. We're gonna pass it over to Alisi to do the last presentation, and then we'll do a Q&A after this. So Alisi, take it away.
Thank you so much, Priya, and thank you, Dr. Valletta and Nasha, for leading this off so strongly and really talking about many of the things that now I don't need to talk about. But before I jump into what I would like to share this afternoon, I just want to pay my respects to so many of the elders who had paved the way, and why am I getting emotional? Have paved the way in this work, who had put in blood and tears and all of their investments in even focus on work on cancer disparities research that has given at least our NHPA community a foundation to stand upon. And even though so much of that work, which happened over a couple of, about 20 years with programs like WinCAR and PATH and so much of the work that was funded through the federal government, a lot of the cancer work has really slowed down in our community in the last decade, I would say. And so this partnership with Appeal is an opportunity for us to shine a light back on cancer, and in this case, lung cancer, for our community, and find opportunities for partnerships that will help continue to increase awareness and bring more resources to our community around this topic. So just want to pay my respects to the elders who have done that work. And part of the elder class here includes Rod at Appeal and Jeff over at APCHO, and so many of the folks who have really stood alongside our community in partnership as we have continued to build through many, many years of work. So thank you for continuing to partner with us. And I also want to just give a shout out to so many of our friends that are attending here who have contributed over those many decades alongside our elders to the work that we get to continue in our community today. So Thank you so much for the opportunity to be here and to be able to share a little bit about what's going on in our community and why it's important to have community partnership in a lot of these efforts. And so I just want to share, I'm currently the executive director of the Southern California Pacific Islander Community Response Team. The shorter name is SoCal PICRT, PICRT. And this picture is, let me see if I can get it to presentation mode. This picture is taken last month at our annual convening. The SoCal PICRT was created during COVID as the Southern California Pacific Islander COVID response team. And we are a coalition of over 20 Native Hawaiian and Pacific Islander serving organizations from Central Valley all the way down to San Diego County. We came together during COVID because we knew that our community was going to be severely impacted. And we didn't have individually as organizations a lot of our own resources, but we knew that if we could pool everything we had, that we had a better chance of responding to this for our community. It has been it's going to be 5 years in 2025. We were started in 2020. And we continue to come together as a coalition to strategize together, to share resources, share knowledge, and continue to maximize whatever little that we might have as individual organizations to serve our community as a whole. And even though we have, many of us have continued our work individually, we decided to stay on as a direct service organization, in addition to continuing to convene our regional coalition, because we didn't have a direct social services organization serving our population in Los Angeles County, which is the county that holds the largest population of NHPI outside of Hawaii. And so it was a huge gap that needed to be filled. Because we have a large population there that is very spread out in a very large county that didn't receive resources and support. And so in addition to convening the coalition, SoCal PICRT is also a direct services organization serving specifically our LA County community. Through the coalition itself, we are helping to build our collective capacity around communications, because we don't have a lot of Pacific Islander ethnic media outlets. And during COVID, that was something that was really necessary, was communications to combat a lot of misinformation that was really penetrating our community deeply around vaccinations, around testing, around COVID. So we are building together our communications capacity so that we are putting out information as a group, and we are able to share information. So if we generate content for social media around lung cancer screening awareness, for example, we will share that with all of our organizations and ask them to please share them also. So it helps to amplify the information that we put out there. And in addition to that, we're helping to support our organizations around infrastructure and capacity building. So we share grants with each other. We co-write grant proposals together with those that need support. And then the third area where we try to really collaborate is around policy advocacy, because we know so many of our orgs are direct service providers. And so we carry their voices with us when we are speaking at the county level and at the state level, sometimes at the national level, to advocate for resources and for representation of our community. We really believe in this collective model. I think it strengthens the work that we do, and it amplifies our voices as a small community. But all of that to say that we exist as an organization and as a sector because information, support, and resources don't reach our community. And even for amazing champions like our national AAPI organizations, it's still a struggle to reach our community. And so we exist to be able to be a bridge and to connect whatever good information, whatever good resources and good relationships to our community directly. And so we as in the coalition and also like as member as organizations, we serve in that way in connecting many of the information and resources to our communities. What I'm speaking to today, and I'll just talk story this because I think Dr. Vlada and Nasha already made the case for why it's important to have people that are from community in this space as community health workers or lay workers, in whatever capacity and whatever titles they might have. Community members are necessary in being able to bring information such as awareness around lung cancer screening to our communities. And I think two big reasons why we are necessary in being that bridge for our community is number one, we are translators, and not just translators in terms of speaking our languages, but also translating the context of information in ways that fit frameworks that are is easily understood by our community that they can relate to, but also like cultural translators. We can take information that can be very technical and very scientific and frame them in ways that is more easily understood, easily digested, and more importantly, that resonates with our community. Oftentimes, there's a lot of really good information that comes to our community, but it's not put in a way or delivered in a way that gets our community to really listen and resonate with messages. And so community organizations play a key role in being translators. And very literally, we provide translation, and many of our other organizations do the same. For SoCal Pickard, we translate. We have translators that help us translate into Chamorro, Fijian, um, Marshallese, Samoan, and Tongan. And when the Native Hawaiian community asks for us to translate materials into Olelo, Hawaii, we have translators on standby to be able to do that. Knowing that some of our translations are important both for understanding for many of our elders, but also it helps many of our community members, even the ones that are first, second generation here, feel seen. They just feel valued when something is put into our language, even if that's not their primary language. So it can be a tool of trust building when we have things that are in our languages, even if that's not the primary language that people use. People feel seen and people feel valued when they see their own languages used in materials. Secondly, just translating context. For example, Dr. Vallada talked about the cancer, the late diagnosis rates in our communities, and I will tell you, cancer as a word in our community is very stigmatized. It draws fear into people. It is one of the challenges we try to overcome in encouraging people to get screened early is because then when they hear the word cancer, it's essentially a death sentence for our community generally. And to be able to translate the context of that, right? Because many of our community, their experience has been when there's a cancer diagnosis, death shortly follows that. That has been the community. And to be able to explain to the community why that happens, why that is the sequence of events that we experience so frequently. And you can explain to them it's because we wait until too late to screen. And by the time it's caught, it's too late for anything to be done. And the reason why we screen late is because many of us don't have a primary care home, right? Like we don't have a medical home. Many of us don't see the doctor often because it's hard to access the healthcare. And so we offer ourselves as navigators to help navigate folks through healthcare systems, but just helping the community understand that the difficulty that they face in being able to face something like cancer screening has a lot of other layers beyond their own individual capabilities. And so to provide that kind of context removes so much of the pressure that our own community members put on themselves, and to be able to offer ourselves as navigators to help alleviate some of the pressure of figuring out this healthcare system, then we become very helpful in that. But it takes folks that are in the work to be able to provide those layers of context to help ease some of the pressure that our community members feel when they hear the word cancer. Because I can tell you that many of them don't get screened because they're too scared of the diagnosis. And so that is also something that we have to recontextualize for our community, around being able to care for our families long term, and for people to stay around longer for their families. So we act as translators in those many ways. And then secondly is that we are navigators, and I've alluded to it already, is that we help figure out what our community members need without them having to ask for it, and help them get to those places. Um, a really key ways that we navigate our communities, we navigate all of the community hierarchies, because our culture is very hierarchical. There are many protocols that have to be observed in order to build trusted relationships, and being able to navigate that for people allows for information to enter our community. So, for example, our churches and our church leaders um, are where our community is, and are trusted leaders, and to be able to enter into church space and be able to ask for partnership, to be able to bring messages around health through the churches, it takes a lot of navigating different relationships, and earning the trust of church leaders themselves. And so our role in community helps to navigate some of those hierarchies. We navigate different kinds of relationships, who is the entry point for certain conversations. Because we exist in community and have to do this often, we help bring bring outside folks into those relationships, and help to make those connections for our community. And then lastly, we navigate our community to resources. And so being in community with folks like Dr. Valletta and Ashia, who have a lot of information and a lot of resources that we don't have, being able to connect that information to our community through our role as navigators can play a really big role. And so I don't know what else to say. I feel like the audience are folks that are already they already know a lot of these things, and I'm preaching to the choir here. But those are two main roles that we play in community, and why it's important to partner in community. And with that, I just want to share that we need your partnerships. I'm gonna be I hope to be able to find out more of Dr. Valletta's work and read up on your research, because even what you shared today, so valuable, a lot of the data. And we could really use so much of that information in our work. And so the partnership to have access to research and data for our community is really important. Partnerships with our API organizations like Appeal and APCHO and so many others is important. And then lastly, the investment in our community. So if there are some of our federal agencies that are here, funding agencies that are here. We need investment in our community to be able to continue this work. You can see in this picture, you know, 2 decades ago when I entered the work, you mainly saw elders in this work, but you can see in this picture, more than half of the people here are like under 30. And we have a really young workforce that are really passionate about helping community. And so investments in and partnerships with our community will help to provide resources and opportunities for growth in our community. And then together we can lift this. So thank you so much for having me share our experiences from the community side. And I look forward to continued work together.
Thanks, Alici. Thank you to all of our speakers. Just want to give you all a round of applause. Thank you for all of the amazing work you're doing in our communities. I just wanted to give the framework. I probably should have done this in the beginning, but I just wanted to lay the framework so you all knew that the reason we set this up was we wanted to show it from reverse. So from the primary care perspective all the way to the CHW being the middleman, and then the community perspective with that. We know that lung cancer screenings is a very new topic. We know in the last 5 years it's picked up a lot of attention. And so we know this topic is very new for our community. So that was really the intention behind wanting to start this conversation in this segue. So I'm gonna lead a quick Q&A, and then we're gonna have some other stuff at the end that's upcoming appeal events and an evaluation for everybody to fill out. So please, before you leave today, please make sure to fill out our evaluation form. So I just wanted to ask, I know Tana asked this question, but I'm gonna modify Tana's question just a little bit. What role, so this is a question for all three of our panelists, so feel free to chime in. What role do you think the community and state health departments can play in encouraging our community members to get screened for lung cancer and to take care of their health in general? Do you want me to repeat that? No. So feel free to chime in, whichever one of you wants to start that off.
You guys are sad. I was hoping you guys so that's the hardest question. That's the greatest question, right? I mean, that's the hardest part. But I do think one of the ways we can do it, and I think this is why this is good that we have webinars like this, right? Even though I may follow some of you on social media or whatever, you may follow me. We really don't know. It's just we don't really know what each other's doing because there's just so much going on. But the way I look at it is this: yes, it's a huge problem. We need to combine, say, me as the healthcare side with the community health worker side. And that's the huge disconnect. I don't see any for lung cancer, at least. I mean, I don't know for breast or for colon or cervical, although it's already kind of ingrained in the Asian community. Like they know to get a mammogram. You know what I mean? Like that's not like stigmatized. Even though it is cancer screening, it's not stigmatized as much as lung cancer screening because lung cancer screening is not only stigmatized like Alici said, because it's cancer, but the smoking aspect, which is already a huge kind of deterrent where you don't see that correlation with colon, breast, and cervical, which are the only reason why I keep bringing those three up is because those are the three that are mandated screening. Okay. Lung cancer screening is going to be mandated by healthcare professionals starting next year, as early as next year. But until then, it's going to be a problem. We're not mandated as healthcare providers to screen you right now for lung, where we are for a mammogram. Like if you come in and you don't get your mammogram and Kaiser, for example, or Sutter or wherever you want to talk about doesn't get you your mammogram, they get docked, right? They get docked. That's a big problem. So we're going to keep harassing you until the cows come home, but not for lung. So I do think you need a community health worker. You saw what I showed. So, but this is an example of how hard it is. I didn't give you the whole story, but the community health worker that I had for my lung cancer screening did speak different languages and did everything. But even then, we didn't have the funding even though the funding's less than say a nurse navigator, we didn't have the funding to keep her. So she went off, did her own thing because she was basically doing it for free. And then we got somebody else in play that didn't speak the language. And I will tell you, I don't have data on this because it's so hard to do that. But it went off it didn't help anymore. So you have to have a little bit of that language and the cultural aspect. And I want to combine it, but right now, until I don't know of anybody else that has been able to combine it, except for this grant that I have for the Asian American community in lung cancer screening. But I think California is where we have to start because the majority of, yes, Hawaii has the highest concentrated amount, but the most overall population-wise, California has the most Asian diverse experience, whether it's Northern or Southern California. So if we can't do it, which we're already, I think there's no one else can do it. So I do think we need to start here in California, and that's not just, I'm being California centric, but I would love to figure out how we can do that. So maybe we can ask the rest of the panelists.
I can go ahead and just provide I don't know if I'm gonna answer fully, but I may ask a question back to you rhetorically. A lot of times when you're having those conversations with, say, health departments or different philanthropy organizations or even federal agencies, you generally have to spend time building those relationships so that they're going to listen to you, right? And APSHO, Appeal, we are only small partners in this. A lot of times, we are also looking for ways in which we can bend the ear of someone a little bit at a federal agency or have those conversations because we've spent years establishing those relationships. And now we can say, hey, how do we get that focus in our communities? And a lot of times, we are the people, right? Not just us as panelists and speakers, but also, folks who are on in this conversation in this webinar today. Like a lot of times you are going to have to go out or find a champion who's going to go and build those relationships. And when you're building those relationships, it doesn't necessarily have to be like, hey, I'm only speaking to you because I want to speak to you about tobacco use or lung cancer screening. You have to preemptively build and proactively build those relationships, knowing that at some point you may come to them with a favor, and also it's a reciprocal relationship, right? They may come and ask you, but once they have an understanding of what you're able to do and you have an understanding of what they're able to do, they may also tap into you as a resource to say translate those resources in a different language or have conversations about what's happening in your communities. And so a lot of the focus really is on being able to cultivate a lot of different relationships. And you may not necessarily know why you're doing it at this moment in time, but in the future it'll be helpful for you to be able to have relationships with your health departments, with different local philanthropy groups, with federal, just one person. And we love that battle minority myth sometimes because it does bring you closer, right? I mean, we don't always love it, but it is helpful. Like if you're in a room full of people, like that's really how APTRO came to be, right? A group of Asian Americans and PI serving folks got together and they're like, what are we doing? Like, where is our voice at the table? And sometimes you do need to look around and be like, who is someone that I want to build that relationship or have conversations with and talk to them about what it is I'm working on. And so, and I don't always love doing that, right? Like sometimes I'm like, I just want to sit here in a corner during this, conference, but it is helpful to be able to do that whenever you can or have your colleagues who are able to do a lot of the relationship building.
I think from my perspective is that the health departments just need to normalize messages around getting screened the same way that, you know, like mammograms were normalized. And once that happens, and once that comes from, say, like a public health department, and our community follows up with in-language materials and advocating through the churches, then our community is more likely to do it because it's not just us saying it, but it's actually like, oh, the county health department is saying it, and and integrated into like preventative screenings that are covered under the Affordable Care Act or whatever, so that there are less barriers to cost. I'm not familiar with it enough right now to know like what's the cost and what people have to do, but if we can normalize it as a practice, if we message it as something that it normally gets done, then our community can then aid in making it resonate further.
Yeah, well said. Well said, everybody. Yeah, I think there's a lot of room to play within our uplifting our communities and really getting them on board with these screenings and really from different perspectives of how do we get them to that place where they're ready to have that conversation about screenings. Another question that came in was, how were the navigators engaging with participants in the lung cancer screening research? I believe it was mentioned that communication was done virtually, but was it a video call or a telephone call? And how many navigators were a part of the study to outreach to 500 participants? So I'm assuming, Dr. Valletta, this question is for you.
Yeah, so great question. It was all phone. And email, but no video visits, because it's kind of hard to set up video visits like on the fly, because these are just navigators outreaching these people that have no idea that they even qualify, because that's part of the problem is most of these patients don't know, or people don't know that they even qualify. So it's a lot of just active outreach. So it's got to be it's a lot of phone calls, leaving messages after an email. And then usually though, it's usually through phone that they get an interaction with. So that answers that question. In terms of the second question, how many we had, the navigators we had. So that's the issue, is that we had to do it because we ran out of funding, or we still have funding, but not enough funding for a full-time person, right? Ideally, you want at least just one full-time person, right? Whether they make, even if they make 50, 60,000, that's, everything's so different now, right? In terms of, so like a nurse navigator costs like 150 to 200 grand a year. That's how much nurse navigators make, right? So that's kind of why, and they may not even be in the community, right? They may be clinical, but we know that you don't have to be clinical nurse to help people get screening, right? It could be a family member, but whatever. So with cultural competency and or language. So we didn't have the funding for that person. So then what we had to do is we took students because they work for free. But again, these students are all varied, right? And so you can see, but even then it's successful, right? But just think if we had somebody from, whether it's Elise's team or Nasha's team, that has like all these a million navigators that I heard about, which is great. But again, like I've never seen a navigator ever funded for Asian American, at least in Northern California. I may be missing out, but in terms of, that's why we're doing these webinars, right? But I've never seen them ever approve that they don't even approve it for all lung cancer screening, right? But then let alone to try to outreach the highest risk group, which in our system, in the Kaiser system, is actually Asians over Black and Latin. The lowest lung cancer screening rate is actually in Asians, not in Black or Latin. And then obviously white have the highest. Right. So if we can't even get one for the overall population, you can imagine how trying to get a culturally sensitive one for Asians are. So again, this is all just totally grassroots, but even grassroots style, like where these students aren't really trained, they're not trained to be a community health worker. They're not like Elise's team that understands the Native Hawaiian Pacific Islander population because they are. This is just random students that are just trying to help me out, outreaching, but even then that can help. But just imagine if you had a full-time person that actually trained in community health working, or went to APCHO or whatever, Elise's group and all this stuff, and learned a little bit about it, or were totally into it. Imagine the sky would be the limit. But to this date, I don't know of anybody that has that, and if they do, I would love to talk to them more about how they got that person.
Yeah. And just another follow-up question for you, Dr. Valletta. Are there opportunities to expand your research study to incorporate maybe portions of Southern California, or even incorporate more of the NHPI voice in that? Because we know many times the AA and NHPI community is often aggregated together, but in terms of data disaggregation, we really want those to be looked at as separate groups. But knowing that the data is just lacking, are there opportunities to use your platform and some of the research you're doing to uplift that a little bit more?
Yes. So the answer is yes. That is the goal. I'm also do this, it's called global faculty or whatever, but through Stanford CARE, which is the Center for Asian Health and Research Education. And the idea is to outreach it to the Native Hawaiian Pacific Islander group as well, because you're right, that is a lower amount that we have. But if you saw in the Kaiser data, which is kind of cool, you actually saw that we did have Pacific Islander in there, and that we were able to differentiate that, which is actually a big deal because in the past we hadn't been able to do that. So with our own data, we can look at it where you can look specifically and try to hone in on that Pacific Islander. But the other way we want to do it is we haven't done with the CBOs, the community-based organizations of Native Hawaiian Pacific Islander. We have with the Asian American overall, like in terms of usually Chinese, it's usually more Chinese-based. We have done a good job with that, but we have not reached out to the community-based organizations for the Native Hawaiian Pacific Islander. So, and obviously I know Elise's down south. So that would be one option to do that, right? Is to try to coordinate down south, because in Northern California, at least, but I need to be enlightened, right? As much, I don't see that big push with that, with the CBOs. And I know Southern California, there's a higher concentration of NHPI, NHNPI, but so I think that's why we're lacking up here in Northern California a little bit. But to answer your question, yes, I would love to collaborate that more. And in fact, would even like to start, because Elise is right. I mean, if we really were to disaggregate it even more, because if we had the numbers, the Native Hawaiian and Pacific Islander are probably worsely affected. To be honest, you just had low numbers, but if you actually looked at it, it's probably the group that's got the mortality rate would go up even higher, because that's what I see clinically, right? I'm a lung surgeon, a lung cancer surgeon. The majority of our Native Hawaiian Pacific Islanders I get, because I also take patients from Hawaii, from Kaiser Hawaii, and unfortunately, most of them are diagnosed younger, and majority of them are not getting screened, and the majority of them have symptoms, hardcore symptoms before they come see me. And so if you already have symptoms from lung cancer, you're usually stage 4 already. And so those patients are just getting, so they're dying because they're getting caught too late, and they didn't know that there was screening. And so, but there's not a concerted effort to go after this population because, again, there's fewer amounts of this group when you talk about Asian American overall. So yes, I do think that this group is actually affected the most, but we need to do a better job of outreaching that group. And maybe that's something we could, talk more about. But the Southern California connection, I think, would be helpful that we don't right now have. We're a little isolated right now. I say NorCal from SoCal.
I want to give a shout out first to Kaiser NorCal for that data. We've actually been using a lot of that data because we try to look to see if SoCal Kaiser somehow also pulled the same data together, and it didn't. So we've been using the NorCal Kaiser data, knowing that what is showing up there, at least for our community. So thank you for disaggregating that, Kaiser. It's probably very similar to what we might see in Southern California population. So we've been using that data since it has a lot of like really specific data. It's disaggregated and it's recent. So thank you, Kaiser, for that. And also, we have a thriving nonprofit sector and organizations in Northern California. I would love to connect you to a lot of them. A lot of them are doing public health work also. And so, yeah, they're just busy doing the work, and a lot of times, we don't always show up in the same spaces. But I would love to connect you to them if it makes it easier that our NorCal folks are connected to you. But hey, that doesn't mean that I'm putting ourselves out of the running either. So if you have colleagues or if you want to also extend your work to Southern California, I would love that partnership.
Great.
Thank you so much, everybody. We're running out of time, so I'm going to move us along. But thank you so much for these great conversations. I'm super excited to carry this work forward and really continue building this partnership between Appeal and all of you to really continue this work with our communities. But just quickly, because we're running out of time pretty quickly, I'm going to pass it over to Jay to talk a little bit, really, really quickly, Jay, about one thing that Appeal had worked on this past month, in the month of November.
Yeah, thanks, Priya. So we just created a lung cancer screening awareness toolkit. This was for November, for Lung Cancer Awareness Month. But inside the toolkit is a bunch of graphics that we created, captions, fast facts that you guys can utilize. It's a very easy download. We'll put the link to it in the chat for you guys to use however you see fit. Thanks, Priya.
Yeah. And then also just a quick plug. We have some other Appeal events happening this week. Tomorrow we have some healing circles hosted in honor of really dealing with the post-election really results with that. And so we'll have a healing circle tomorrow at 10 a.m. and another one at 3 p.m. And for our folks in California, there is some funding opportunities to start the conversation around tobacco control work, specifically in the state of California. So if you're working with the A and NHPI community, we will share this information via email as well, so you all can get it. But we just wanted to put those plugs out there really quickly. And the very last thing I have, because I promise we need to do this, is evaluation. I would love if all of our participants could please fill out an evaluation form so that we can host more events like this. Your feedback is truly really important to us so that we can ensure that we have the opportunity to continue building off of this conversation. If things are coming up for you all, like, feel free to put it in there. So that way we know if we were to do another segment of this series where we do want to focus. You can scan the QR code, and I think Jay's trying to put it in the chat, right?
Yep, I just put in the chat for you guys.
Perfect. So yeah, please fill this out before you head out. And we will send this out too. So yeah, but please fill it out. And yeah, just with our 1 minute that I have left with you all, just again want to say a huge thank you to our speakers today. Thank you so much for joining us today. Thank you to all of our participants for joining us and staying with us for the whole hour and 30 minutes. Special shout out to our team at Appeal. So we have Rod, who's our executive director. My name is Priya. I'm our program coordinator here at Appeal. Tana, who is our NHPI liaison. And Jay, who is our program coordinator on our national team. Please stay connected with us, if you go on our website, appealforhealth.org/membership, you can join our listserv to stay up to date with any of our upcoming appeal events. And feel free to stay in touch with us through social media. We are using our Instagram pretty often, so you can really look us up on there. Feel free to tag us if you all are seeing things. We would love to learn more about this topic. We are learning just like everybody else is learning. We're all learning together, and really just really wanting to advocate for our community. So please join us and stay with us on this journey. Yeah, with that, I'll wrap up today's event. Thank you so much again for joining us, and we really appreciate it. And we look forward to continuing this conversation with, again, our advocates and also just our community members as well. So thank you so much. Have a great rest of your day.